Welcome to the Orthodontics in Summary podcast, where Farouk brings you the key points and understanding of orthodontic webinars, conferences, and papers in a concise podcast with your host, Farouk.
Welcome to this episode of Orthodontics in Summary. Today's lecture is a part 2 of last week's podcast entitled My Rules in Orthodontics by Mohammed Al Muzian. In this podcast, we'll be exploring the topics of which tooth to extract, Anchorage assessment and its management, the bonding of second permanent molars, use of elastics, and the difference in treatment planning between adults and children. So to start off with, the decision to extract, is it going to be the first premolar or the second premolar? First bicuspid versus the second. Now, Mohammed had a neat way of assessing this using the acronym CAT-V. So I'll explain. The CAT, the C stands for clinical condition of the teeth. The A in CAT stands for anterior crowding. If it's 8 millimeters or greater, it necessitates the extraction of the first premolar or first bicuspid. If it's less than that, it could be either the first or second bicuspid. The T in CAT stands for transverse, and extracting of the lower second premolars or bicuspids will help to narrow the arch. The V in CAT-V stands for vertical, and extraction of second bicuspids or second premolars is preferential in high angle cases, and we'll get the advantage of the hinge effect, allowing us to improve or increase the overbite. Next, Mohammed went on to describe the molar outcomes of orthodontic treatment and how our extraction pattern influences what our aims are. Mo started off by describing a non-extraction case and the extraction of 4 premolars or bicuspids having the same outcome as class 1 molars. He then built on this and said if we only extract 2 units in the upper arch, we should be aiming to finish class 2 molars. Likewise, if our only extractions are carried out in the lower arch and we have 2 units removed, we're therefore aiming to finish class 3 in our molar relationship. Now, what can confuse the equation are the first molars. He described these should be ignored when it comes to the treatment planning outcomes of the molar relationship. Next, Mohammed went on to describe anchorage, and he gave 4 very clear categories, which I'll go into describing. Type A is absolute anchorage, where we can have no anterior movement of the posterior teeth. This requires the use of TADs or headgear. Type B is where we can afford 25% mesial movement of the posterior teeth, and for this he described use of headgear and Nance palatal arch, intermaxillary elastics, and the extraction pattern to help control it. And he gave a quick clinical tip, and that was that a Nance palatal arch is effective at this type B anchorage. However, it isn't good at correcting overjets. As we retract the anterior teeth, the Nance palatal button will dig into the palate, so we need to ensure it's just to get the canines back to class 1 and for crowding relief. Type C anchorage is where we can afford 50% mesial movement of the molars and posterior teeth into the extraction site. Now, this is reciprocal anchorage as Mohammed described, an equal amount of anterior retraction equating to the posterior protraction. And type D, this is where we require 75% of posterior mesial movement into that extraction site. And for this, we actually need anterior anchorage to facilitate, using reverse headgear or using TADs. Next, Mohammed went to speak about anchorage and how the loss of anchorage in the lower arch is less than the upper arch. And he described why. It's due to difference in bone densities, difference in root surface areas, also related to the buccolingual width of the molars. Mohammed then went on to describe this use of bonding second permanent molars in the upper arch, and he said, don't bother. Anchorage associated with the upper second molars is very limited. Also, they are distally tipped teeth, which means when they are included in the arch, they upright. In doing so, they absorb space and therefore anchorage. Mohammed spoke about intermaxillary elastics and spoke about using class 2 elastics, for example, on non-growing patients does result in a rotation of the mandible. He described the rate of overjet change with intermaxillary elastics and how at maximum we can achieve 0.5 millimeters of overjet correction using intermaxillary elastics. He described the ratio of vertical versus horizontal movements with elastics. Typically with class 2, we get a nearly 1:3 ratio. So for every 3 components of horizontal change we get with elastics, there is 1 vertical component of change. He mentioned be aware of using unilateral elastics. They will create extrusion on one side, resulting in occlusal canting, and he gave another clinical tip to use box elastics on the opposing side. He mentioned elastics should not be stretched more than 3 times their diameter, as that's the limitations from the manufacturer. Distalizing, he said, be realistic with your expectations on how much we can distalize. No more than 2.5 millimeters is Mohammed's advice unless we extract the second molar or the third permanent molars. And finally, to conclude, Mohammed compared the management of treatment planning for a growing patient versus an adult patient and demarcated differences in treatment planning due to that growth factor. So he described the opportunity to use functional appliances to get greater distalization and greater changes with intermaxillary elastics was prevalent in planning a growing patient's case. On the contrary side, adult patients leaning more towards extraction therapy, less dependency upon elastics, and very limited distalization as a consequence. That brings us to the end of this lecture. Hope you guys have enjoyed it. Please do subscribe and look forward to the next episode.